Okay, hello everyone. I'm Dawn Sim, and I'm a consultant ophthalmologist at Moorfields Eye Hospital. Thank you for your time for listening today. I'm going to talk about the futures here for patients with age-related macular degeneration, touching on home monitoring, video consultations, as well as new treatments. These are my disclosures. I'd just like to start, to talk about what we've all been going through over the last few months. We audited our intravitreal injections for wet macular degeneration as well as other macular diseases in Moorfields South, which is where I do clinics for patients with wet AMD. I looked at what happened during the pandemic, and this was an interim report that we prepared. And the total number of patients affected within our medical retinal service was just over 4,000, of which over 600 were in active treatment in our injection clinics, and about 400, so about a tenth of those patients had stable monitoring clinics or virtual clinics, and I'll touch in on that. And what we did was a huge, large-scale risk stratification exercise during lockdown because patients were not able to attend clinic appointments, and we wanted to know who needed to come most and who we needed to get in touch with more urgently because you can't ring 4,000 people all in one go. So patients were put into categories high, medium, and low risk. And it really, in the figure you see on the right there, it's just illustrative to say, this did not occur just in the medical retina service, but across the board in glaucoma, pediatrics, general ophthalmology, etc. And what we found that high-risk patients within the medical retina service were about, on average, a decade older than patients with low-risk disease. So this was a particularly vulnerable group of patients that during the period of lockdown, I think uh, a lot of these patients were shielding or did not want to attend hospitals for a very good reason. So, how can we deal with this situation? With two of my colleagues in the digital clinical laboratory at Moorfields, Peter Thomas and Chris Canning, we wrote an article in the Ophthalmologist magazine talking about tackling COVID-19 with telemedicine. And really for obvious reasons, with the pandemic putting frontline healthcare workers as well as patients under mounting pressures to attend the hospital, how can we keep everyone safe? And I talked about risk stratification, and this is really not isolated to ophthalmology. It is something that is used across healthcare and a recognized strategy for managing healthcare surges, which is what we're seeing today. The key to successful implementation of forward triage, which is what we're talking about here, is a good risk stratification criteria. And this really, how do you decide if somebody has really urgent eye problems compared to someone who has stable eye problems? You have to include the elements of data that has already been collected from patients, and in the electronic medical record or the clinical notes. And traditional elements will include a history that's taken and objective measurements such as your vision, your eye pressure, or any photographs that's already been taken of your eye. But what else can we look at? So this is what I'm going to talk about. I've touched a little bit about risk stratification. I think when you talk about technology and digital health, you have to always talk about artificial intelligence or AI. So I will speak a little bit on that. And then diagnostic imaging clinics or virtual clinics, applying telemedicine in the hospital setting. And then lastly, I'll touch on self-care and home tests and what can you do at home to facilitate good data collection to allow clinicians to risk stratify when you need to come into hospital. So these are things that really were triggered by new treatments that are on the horizon for wet macular degeneration. I see that Many of my colleagues are going to touch on new treatments for dry macular degeneration, so I won't be speaking about that today. But this is the port delivery system that has just in July been announced that phase 3 data did really well. So how this works is most people with wet macular degeneration have to attend either every month or every 2 months for an injection of a drug into the eye. With this port delivery system, what they found was 98% of patients only required refilling of this port depot of medication just twice a year, compared to between 8 to 12 visits to the hospital per year. So this is very promising, and they found a non-inferiority in terms of comparison with standard treatment, which was monthly injections. And so this is on the horizon, which I think uh, for most people who have to attend hospitals every 4 weeks, it has been very exciting. Novartis has also just less than 6 months ago, well, 6 months ago now, released a new drug that has, so at the moment, most patients have treatment either every 4 weeks or 8 weeks, and that's extended to 12. But this new drug actually allows extension up to 16 weeks, every 4 months, equivalent to 3 visits a year. There has been problems with this medication, with inflammation in the eye, and hence the delay in introducing it on a wider scale across the NHS. But the trend for longer treatment intervals really has sparked off the question of how do we keep track of patients' progress? How do we monitor them if we only see them 2-3 times a year? So longer treatment intervals has triggered the kind of question of how do we use digital health and AI? Can we facilitate this new era of new treatments? So I think the other factors of access to eye care, costs, hospital capacity, and the experience also will be touched in this. So a little bit about artificial intelligence. So where are we in terms of using artificial intelligence into our day-to-day practice? So we're kind of there. I think we've moved very, very rapidly over the last few years, but we're at the stage where algorithms seem to work. We can demonstrate it works, but there is a huge chasm before scalable deployment of algorithms that can help make diagnoses or make predictions of when your disease might be active is used in a day-to-day service. But saying that, there are users of artificial intelligence algorithms, not so much for replacing what doctors and other clinicians do, but they're pretty good at predicting hospital attendances. So this is a study done at the University College Hospital, and they found that they could use an algorithm to predict who would not come for their appointment. And we know that do not attends or DNA rates are a huge problem, which actually wastes slots that could be used for patients who would attend. And this is a global pandemic, so research has shown that the rates of do not attends are high across the world, not just in our UK setting. So as you can see here in the African continent, it's about 40%, South America, Asia, North America, in between 20 to 30%. So what this algorithm did was they correctly identified 90% of the patients who would not attend. And this reduced the number of people we are required to call from 11 to 5, so half the number of people you're required to call to prevent one missed appointment. And it doesn't sound like much in a small scale, but across the NHS, the cost savings were estimated to be about £1 billion annually. So this is a very important thing to do. What about Moorfields? So what have we used artificial intelligence for in the real world setting so far? So a chatbot has been launched at Moorfields, not to take a medical history, but what it does is the users of this chatbot can ask the chat robot about what's happening with our move of the hospital. There's a planned move of the hospital to a different site, and they can find out about events, discuss, provide feedback. And this is Peter Thomas, my colleague, which I mentioned earlier, and he's headed this project up and given it a brilliant acronym, the Moorfields AI Assistant, or MAIA project. I love that acronym. What about video consultations? What I've been doing? So this year you see the team, again, Peter, myself, and Sarah Canning, who's our head optometrist at Moorfields. And this is Palin, who is a consultant ophthalmologist at Moorfields in accident and emergency. So in the period of lockdown, probably since the end of March this year, video consultations has skyrocketed. Prior to lockdown, the total number of video consultations done at Moorfields was 0. And so far, in the 4 months ensuing, we've done over 10,000 video consults. And this is what you'll find when you come to our website, video consultations, how to attend, etc. There are booked appointments, but there are also a drop-in appointments, so like accident and emergency setting, where you'll be triaged by a human being. There is also a human virtual receptionist who will take your details and signpost you to the right waiting room. So this is my view, because I look at patients from Croydon in medical retina, and we also have a uveitis service as well as a tele-pharmacy service. So you can tell how many patients are waiting for you in your waiting area, how long they've been waiting, etc., etc. And this is just an example of a YouTube video onboarding doctors of how to use the platform. Is really, really easy. So that's Peter at home talking to a potted plant in his other room. That's me again doing video consultations. What you can do in these consultations, which I find really, really useful, is invite a guest. So if the patient is elderly and shielding at home and their family is elsewhere, but they want a member of their family to join the consultation to take notes, etc., or a translator, you can do this via this platform as well. Just a few case studies to share what happened. In Moorfields Eye Accident and Emergency, we normally see about 250 consults per day. And post-lockdown, and understandably, only about 64 per day. The total number of video consultations we've done so far, as I said, is over 10,000, and a vast majority of which has been through the Accident and Emergency Department at Moorfields in City Road, Central London. The percentage of those that had the video consultations that required a further face-to-face consult was in about 20%. So only a fifth of patients that had a video consultation required to come in, had to come into hospital for a further consult, which I think it's pretty impressive. Our oculoplastics team, and the teams that takes care of eyelids and the orbit, has also been early adopters of video consultations, and this is just one of the first papers produced by the department. Here, and you see a plethora of eyelid conditions that were seen using video consults. And if you ask about medical retina disease, I think people always look at me with skepticism. How can video consultations work? So what we've used it for predominantly is, yes, finding out if patients are symptomatic, so if the vision's gotten worse. We also use it to explain results of scans to patients who otherwise would have had to come into hospital just to have a chat to a consultant. But we've also been training people on how to use their smartphone to monitor their vision at home. This is just one example of, as you see in the figure 1, 2, 3, 4, is what you are shown on your device when you are onboarding to learn how to use the application to check your vision. And I myself have done quite a few of these video clinics, and we give about 20 to 30 minutes per person over the course of a morning or an afternoon, and spend that time talking about not only their condition, but teaching them how to use the application and why they're using the application, which I'll come to later. So I just wanted to talk about virtual clinics for a second. So here you see pictures of two of my colleagues from a few years ago now. This is 2016, so going back about 5 years. So this is Dermot, who is our ophthalmic technician, and Alicia, who is our ophthalmic nurse. And both of them run a virtual clinic together with a receptionist and usually another technician in one of the community hospitals in London. And what they do is the patients come, they're asked a set of questions, and they take an image of the patient. This retinal image or OCT is read at another time by another specialist, usually an optometrist or consultant ophthalmologist, and the patient's given a full report after that. So this has worked really well and really has been running for more than a decade now, but probably about 5 years ago, these types of diagnostic imaging clinics have scaled tremendously. So there are more and more of them, and I'll come to why. But there's been a bit of an identity crisis of what to call them. Are they stable monitoring clinics? Are they diagnostic imaging clinics? Are they teleophthalmology clinics? I think we've kind of settled on to the diagnostic imaging clinics because virtual clinics, I think, can be a little bit confusing. But that's what we called them in the beginning. So about 2 years ago, we looked at the virtual clinic patients that we saw, just under 2,000 of them. And we found that in the beginning, we were not so good at it. A third of the patients had to come back to see a doctor face to face. But we improved on this just a year later by upskilling our technicians and teaching them how to take good images, how to take better images, and how to ask the right questions of patients as well. So image quality in the first year that we were running the service, the poor image quality rates were really high, about 30%, and this dropped right down to 1% just a year later. And we were finding that patients that had to come back to see someone face to face usually had worsening of monitored disease, which is really the whole point of these diagnostic clinics. We also improved the way we collected clinical history information from a patient. When you see a doctor or consultant, usually there is a face-to-face encounter, and then symptoms are reported, questions are being asked. But if you come just for a scan, or if you see a technician who may not have so much experience in asking questions, how do you enable the right information to be gathered? So we've been working with a company called Big Picture Eye Health and developed what we call a smart clinical history, where one question leads to the next, and it's quite intuitive. So first question, for example, how are you feeling since you were last at clinic? Are you better, same, or worse? And if you are worse, it goes down to ask a whole series of different questions. So is there vision loss? Is it for near? Is it for distance? Is it quick or slow? Etc. So it gathers the right amount of information using the smallest amount of time, and it also leads to asking for the right tests to be done. So a lot of time, patients will have the scan or the other scan, and you go, oh no, but I need that one as well. But what this supports is it supports the ophthalmic technician or nurse who has to acquire these images, and it tells them which ones to do. For example, if you have diabetes, you don't have to check your HbA1c or blood tests for your average blood sugar over a period of 3 months at every visit. But perhaps you can set it to once every 6 months, or once every 3 months, or once a year. So it automates a lot of the processes of data gathering. So on the other side, when somebody looks at the gathered data and has to report on the scan, what we've found very useful is that all the information is displayed in a single view, and you are able to make a diagnosis with the least amount of clicks and minimal typing, which saves time as well and improves the efficiency of the service. The structured data collection is linked to a pathology tree as well. So this information can be gathered in a way that can be used for research to further automate this pathway for the future. So I think when we talk about diagnostic imaging clinics, people always say, oh, but don't patients just want to see a doctor? And in our experience over the last 5 years, we found that this is not always true. I think a lot of these patients that we have in the virtual clinics have been in our service for some time. They have stable eye disease. They were previously treated, had been stable for 6 months, a year, and they found that in this cloud-based teleophthalmology pathways, you see the time spent in hospital is less than an hour, and we found our average time was between 30 and 40 minutes compared to usually several hours in the conventional pathway. So the acceptability of the pathway has been very, very high in our surveys. For these patients. And there is also good evidence from the US as well of acceptance of telemedicine services. And they found that this actually was superior to traditional face-to-face consultations in a screening setting. And this randomized trial, where they compared face-to-face to screening using telemedicine, attendance was higher in the telemedicine-based methodology. And when they did a little flip over, when the face-to-face group was invited for a telemedicine setting, attendance improved as well. So that was quite surprising even to me. Perhaps it was a much more streamlined pathway. It's difficult to say why. And I think lastly, I've given a very kind of quick overview of diagnostic imaging clinics. We talked about risk stratification. We talked about data collection. I really want to talk about how we can enable people to use devices that 80% of adults in the UK have one of these. And how can you use one of these to check your vision at home? And I think the time has come where, unfortunately, we don't quite have a home scanner yet, although that's on the horizon. If we had an OCT at home, that would be the gold standard because it gives you the anatomical truth of how your macula is doing. But prior to that, I think you can do some tests at home, and that's what we've been pursuing over the last year. I think most of us are familiar with the Amsler grid. It's the bane of most people's lives. You put it in your fridge, you look at it, and then maybe you say, okay, this is what I see. And the problem with this test, I think, is that there's no way to record it, and there's no way to really detect change in an objective fashion. It's quite it's a subjective test. It's good to it is all we had for a long time, and it's all we have in most places, and so it's very widely used. This was first described more than 70 years ago, and it measures hyperacuity, which is really the ability of the human eye to detect even faint alterations in shapes or straight lines. And how reliable is this test that we ask people to do at home, once a week or a couple times a week? A systematic review, which was conducted in 2014, found that the sensitivity of the Amsler grid was not great, so 0.78 as you see here, but the specificity was very good at 0.97. What does that mean? So if you have an abnormal test, it's very likely that you have a problem with your eye. But if there's a problem with your eye, it may not detect it. So what does this mean for us, and where can we use it? But before I talk about the Amsler and the smartphone, I want to look at what evidence is there for monitoring your vision at home. So the HOME study, which is quite a nice acronym again, which was part of the AREDS-2 study. AREDS-2 is a study on vitamins preventing conversion of dry to wet AMD, which a lot of us are very familiar with. This was an arm of that trial. And what they found was when they gave patients with intermediate dry AMD a device at home, and then in the other arm, the standard of care. And when they gave them this device, there was a smaller loss of visual acuity in the device arm compared to standard care when they converted to wet AMD. And this study was actually terminated early because of that. And the conclusions were that people at high risk for choroidal neovascular membranes benefit from home monitoring for early detection and better visual acuity results after treatment. So this is as robust data as you can get really for home monitoring. But unfortunately, the device, as you can see there, is quite large, and it's not something that everyone has easily accessible at home. This is I wanted to put this in here because it talks about gaming to improve vision. I think there is a lot of ageism when you talk about smartphone use, but actually there is a very high prevalence of smartphone users, even in the patients with age-related macular degeneration. And in this Australian study, where they asked patients with intermediate AMD, so not anybody, but people with intermediate AMD at risk of converting to wet macular degeneration, how often do you check your vision on the AMSLA chart? Almost half said monthly or less, so they weren't doing it. But when they asked them the question, how often do you play games on your electronic device? More than half said daily or more. So there is high usage of the smartphone. Um, we really wanted to apply this in our clinical setting, and this is Miriam Islam. She's my Topol Digital Fellow, and she was successful in getting one of 18 grants that was cross-specialty, so not just in ophthalmology. So the first of one of 18 fellowships around the world. So she was using the smartphone application called All Eye, and teaching patients how to monitor their vision at home. And at first, we looked at patients with diabetes, diabetic macular edema, but we have also subsequently looked at patients with AMD. So how does All Eye, which tests that area of the macula, see there is about 12 degrees of field compared to the AMSLA chart? So the reliability of this, what we ask patients to do is align dots on their phone using the arrows on a touch screen, one eye at a time. And they do this 12 times in and around that area. And it gives them a score, as you see here, from 1 to 100, that's 69. And it uses a red flag system, a traffic light system, green, amber, red. And when you hit a threshold of 3 reds in a row, it triggers for us a telephone call or a video consultation and moving the appointment forward. So, for example, if you were planning to see somebody for an injection once every 4 months, and they hit a red flag traffic light system of a red, red, red 3 times, at 8 weeks, that would trigger a telephone consultation with the patient. So this data was shared with me by All Eye, and they've done work to look at the sensitivity and specificity of using All Eye. And the numbers of which for AMD compared, as you see on the blue, and for DME is 0.93, 0.92. So comparable and higher actually than the AMSLA grid. For monitoring, what we found was that the false alarm rate was 6%. And that's really, really important here, because what happens is if you have too many red flags and too many false alarms, it not only unnecessarily worries patients who are using this application at home, but it would also trigger too many unnecessary appointments being brought forwards. So we were very pleased by that. Just sharing a little bit of our work in lockdown. In 4 months, 231 patients were taught how to use the app by a team of about 12 of us who work at Moorfields Eye Hospital. And so far, almost 5,000 tests at home have been done. And we've had about 30 red flags, all of which triggered telephone consultation. I'll just share that with you. So I'd just like to end with a case study. This lady very, very kindly allowed me to share her story. So she's a 70-year-old lady who's retired, and this is actually her phone, and she has bilateral diabetic macular edema. So she's had injections since the beginning of last year, and she was self-confessed bad with technology. We managed to convince her to use an iPod Touch, which we provided on loan to test her vision. And she's become one of our champion users, and she loves using it and actually does a test every day. We only recommend doing a test 3 times a week, but if you want to do it every day, it doesn't do any harm. And what happened during lockdown? So here you can see what she was like over time. So as you see, there is always variability in any testing. But it's only 3 reds that triggers an alarm, an alert. And she was going, green, 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 amber, a little bit of red, and a lot of it has to do with attention. So if you're tired, if you're bored, the test tends not to be very good. But in lockdown, which is the yellow arrow, she was still in the greens. And the green arrow, she started getting red signals consistently. We contacted her at that time, but she was not keen to come to hospital at the height of COVID. She finally agreed to come into hospital on the 8th of June is when I saw her, and she had felt that her vision had gotten worse over time and wanted to be seen. And these are her scans. So she had an injection in both eyes in January of 2020. That was her last treatment. As you can see on the OCT scan, it looks almost completely dry. We have this nice foveal contour. Vision was very good. But by June, she had not had treatment for almost 6 months by that point, and her edema had accumulated in both eyes. You can see the fluid cysts in both maculae, much thickened, also fluid under the retina as well, as you see a little hump there. What was really heartening was that 2 days later, after her injection, her scores went back up to green again. And so we continue to monitor her in this time. So there are many of these stories that are emerging from the period of lockdown, but it's early days as we are still catching up with patients that we could not see in that time. So I think just to summarize, I talked a little bit about teleophthalmology or virtual clinics or diagnostic imaging clinics. We are really on the rise, and I've showed this slide before, probably about 4 or 5 years ago, when I was really struggling to convince people that in order to see people when they need to be seen, we need to be utilizing diagnostic imaging clinics to fit them in. AI-assisted consults are still not here, but are here is on the horizon, and proportionately, face-to-face consults will decline because of the overall rise in the prevalence of disease. I think in the time of lockdown, there was almost a forcing of this drop in face-to-face that wouldn't otherwise have happened. But proportionately, I think when you look 5 to 10 years time, diagnostic imaging clinics will have to rise, and face-to-face consults will come down. And I think just to bring this back to the beginning where we talked about new treatments, the goal of new treatments so far, yes, drug discovery is important, but I think enabling patients to not to have to come to hospital every 4 weeks is really a very important goal. But whilst doing that, we need to ensure we are still monitoring the level of vision and seeing people when they do need to be seen. And thank you very much for listening, and I'm happy to take questions.